Hello and warm welcome to MedSynapse podcast series where we bring you insightful conversation with leading experts in medical field. Hi, I'm your host Dr. Smarika Bhatt, and today we are joined by Dr. Vaibhav Chaudhary with us, who is the Director Medical and Precision Oncology in Nanavati Max Hospital, Mumbai. Welcome, Dr. Vaibhav, to the podcast. We're excited to have you here.
Thank you. Thanks for inviting me.
Okay, without further ado, we'll start with the first question. That is, in your clinical experience, what biomarkers or molecular signature have proven most actionable for guiding treatments decision in stage 4 cancers, and how has that picture evolved over the past few years?
Yeah, this is very important because this is the new thing which has come up in oncology, especially dealing with stage 4 cancers. Uh, 20 years back, there was only chemotherapy. Then we started developing some targeted therapies. And the basis of this targeted therapy is a test called as next-gen sequencing or the molecular profiling, or you can name it as a precision oncology. So the story started some 20-25 years back when we started getting something beyond chemotherapy, and that seemed to act better than chemotherapy, and also there would be less side effects with these kinds of drugs. So there was a lot of interest in developing these tests, finding out each and every mutation, why this cancer happens, and what are the driver mutation and which can be targeted. So in a simplistic way, almost when this era came in of precision oncology, we had this thing that we will just go on and do a next gen sequencing, study the DNA in detail and find out all the mutations and treat them accordingly. But cancer is not that simple. Out of this, we have tried in almost every cancer. There are 200 different types of cancer in a human body which can occur. Out of them, there are few, like the commonest cancers are lung cancer, breast cancer, colorectal cancer, prostate cancer. So these have been studied in depth and detail, and we have many targeted therapies there. Of note, the success story for medical oncology is lung cancer. We can give few examples like EGFR targeted therapy. There is a particular mutation EGFR. For that, the target therapies are very good. A simple pill will take care of the cancer for years together. ALK is one more mutation for lung cancer. There are now, as per the guidelines, more than 10 such targeted therapies which can be offered to a lung cancer patient. That goes into show that not every cancers are same. They are different molecularly, and if we go into the depth and then treat them, it is more rewarding for the treatment. Second, most important, while doing this next gen sequencing or DNA analysis for precision oncology, we come across certain markers for immunotherapy as well. These things for target therapy, we find out a mutation and just target it. There are certain pointers which actually give an excellent response to immunotherapy. One of them of note is microsatellite instability, which we find out by doing certain tests on the tumor DNA, tumor biopsy. And if that is there, then these patients respond remarkably to immunotherapy to the extent that even stage 4 cancers, it's not surprising to see such stage 4 cancers which are MSI high, the tumor actually disappears with immunotherapy. So not only for target therapy, for immunotherapies also, there are numerous such examples across tumor types.
Okay, that was an amazing insight regarding the biomarkers and everything. So let's move on to the next question is, one of the ongoing tension in oncology is balancing novel target therapies with time-tested standard of care options. So how do you navigate that when you are developing a treatment plan for someone? So which advanced metastatic diseases, especially when time is not on this side, how do you decide?
Right. So we need to understand what is driving the tumor. Mostly, the chemotherapy is the go-to drug when the tumor burden is very high and patient is suffering because of the mass effect of the tumor itself. Because chemotherapy being non-specific, it actually cuts down the tumor burden very fast. But then for a patient who is already suffering, already is not every patient is fit for chemotherapy. Some might have raised creatinine, some might have raised liver enzymes because of the metastasis, some might not be fit also. So for them, we have to look at certain actionable mutations. Now we have so much of data with these targeted therapies. Some of these target therapies, like some pills or some targeted injections, they actually act faster than chemotherapy also. So ultimately, it's the clinician's judgment to see what scenario we are working on, what kind of tumor is there, and what tumor burden is there. For me, it's like a very, very personalized form of medicine. One plan doesn't fit all. You have to see the patient's case by case and then make a personalized treatment plan for every patient, be it targeted therapy, be it a very low dose of chemotherapy which patient can tolerate, be it a immunotherapy, or be it a combination of all three. That also can be given. There are guidelines for all these things. We first of all, in first line, when we are treating, when a patient presents to us in our OPD untreated, patient has just been diagnosed unfortunately in stage 4, then we just have standard guidelines for each and every cancer. That is across the board. That will be the same decision which I make, which may be made by someone sitting in US or in Europe. It is standard across the board, because there are certain tests which needs to be done. Obviously you cannot proceed without them, and the problem arises when your first line is exhausted and patient progresses on that, and then second line, third line, there are not many options. Rather, patient is also not very fit to receive the strong chemotherapy or the combination second and third line. So there the personalization and the precision takes over from the standard guidelines, and there you have to basically test these tumors. Maybe there are newer biopsies which we do. Tumor might have changed its nature from the initial treatment, and now we might find something else which we can target. If patient has progressed on certain therapy, there are reasons. So it's kind of finding out cause for everything. First, finding out a cause for why cancer has occurred. For example, a 20-year-old comes to me with a lung cancer, no smoking history. It is not explained by anything. It is not explained. It's not an age to get a cancer, but we do see such patients. One such patient I strikingly remember also. So there we think in molecular terms. For that particular patient, it's imminent. It's very important that we actually study the tumor in greater details, find out what it is. Might come out to be something very surprisingly effective remedy for that. So case to case basis you have to see. And beyond chemotherapy, now as we are moving further and further away from chemotherapy, the last chemotherapy drug which was made was, I think, more than 10 years. We have not made a single new chemotherapy. Whatever advances have come, they have come in targeted therapy, immunotherapy, and something beyond chemotherapy, that is antibody drug conjugate, which is a combination of a targeted antibody with a chemotherapy moiety inside it. It is a very, very targeted form of chemotherapy. So newer drugs which are coming in today are ADCs, and chemotherapy are now taking backseat more and more. And with these new drugs and their combinations with immunotherapy, we are getting a very good signal.
So, Dr. Vaibhav, as you have touched upon this answer, that one treatment option is not for all, you have to customize and strategize according to the patient. So, can you tell a situation or a case where genomic profiling or targeted therapy for a stage 4 cancer patient led to treatment decisions that wouldn't have been considered under traditional protocols? And how did the change impact their daily lives with long-term planning?
Yeah, so there are many such cases, because it's my job basically to deal with such cases. So strikingly, what comes to your mind is a very young case, as I alluded to earlier as well. A 20-year-old lung cancer comes to me 6 months on after the treatment. The patient was diagnosed as a lung cancer. Those tests were done, which we actually do for the biomarker profiling and all. And it was a limited panel which was done, and it turned out to be negative. So no targetable actionable mutations were seen in his sample. He had brain metastasis to start with, and widespread lung cancer everywhere, bones and liver and lungs as well. So patient was given chemotherapy 4 cycles. Then patient did well for some time. In 6 months, he again relapsed, and the tumor became refractory. patient's general condition deteriorated. To find a ray of hope, actually, patients do go around to different places, and then they come for precision oncology kind of a thing. So they came to me. I just saw that there is something off here. There is something wrong. That are we missing something? That is a question that we need to ask. That first of all, a 20-year-old boy should not get a lung cancer. Smoking history is irrelevant at that age, because you need some good smoking history to get lung cancers for that. And that's why I had a very high index of suspicion that I might find something which will be a game changer. That was my intuition, purely my intuition. We had a test which was negative. We had a limited panel NGS, but still, since they have come up, we need to do each and everything. And I also didn't want to give up on such a young guy. I just told him that you bring in your tumor block, the biopsy which you have done earlier, and we will retest it for certain mutation. And in the meanwhile, because he was suffering, he was having a lot of pain, so I restarted him on a very low dose of chemotherapy, which won't harm him but will benefit him. So this is usually practically what I do on a heavy disease burden patients. So first cycle we gave on a weekly basis, a very small dose. He had very good symptom relief, very good pain relief. And by the time, I think 4 or 5 days, we got the report that his tumor was ALK positive, ALK positive. Now, if you speak to medical oncologist and you say ALK positive lung cancer, everyone's eyes would light up, because we have now such breakthroughs in this ALK positive domain. These tumors comprise typically 5 to 8% of all lung cancers, typically occur in young patient, non-smoker. Most of them, they do come up with brain metastasis as well. So this clinical picture was fitting there. And there was a report earlier as well that ALK is negative, but that was done by some other methodology. So there are 3 ways in which you can test ALK. So I did it just with immunohistochemistry. I got the result within 72 hours. And we started on the drug. That drug is very potent, very effective, and symptomatic relief started in 10 days. It has been 4 months since that patient is on that drug. We stopped all chemotherapy for him, and just that simple pill he's taking, 1 pill a day. He just came and met me last week with a scan which showed there is 90% reduction in tumor burden. He is again hale and hearty, fit as he was before getting that disease. And more important is not to show that in 3 months he has come a long way, because this is what happens with chemotherapy, with targeted therapies. These tumors are prone to get resistance, and then in the next 3 or 4 months the story may reverse, right? So when you are treating a 20-year-old, you want to plan out for next 5 years, 10 years, and you should be more ambitious rather than 3 months or 6 months of response. So the drug which we had actually started for him, there is a robust data for that drug that the median progression-free survival for lorlatinib, which drug for ALK mutated tumors, is in excess of 5 years. They have not even reached that level right now for 5 years data. So data backs it up. So that is kind of a very fulfilling for me, that the patient came and laid his trust on me, and we were able, through this molecular testing and precision medicine, we were able to help him and change his life virtually.
Case of the guy who has lung cancer, but he was 20-year-old and no history of smoking. So is it possible? Because what will be the reasons that it is possible? Like, can we have genetic reasons, or can we have something else?
Yeah. So for this guy, they had done a hereditary genetic panel as well, which again came out negative. So not all cancers which come in young age are genetic or hereditary. Yes, cancer is a genetic disease, but it is caused by a somatic mutation, a mutation which comes not in the hereditary line. It is not transferred from parent to the child, but occurs on the cell. And that kind of a mutation may be related to smoking. Smoking leads to mutations and leads to cancer. May not be related. There are many things about cancer which we don't know. Honestly speaking, being an oncologist, being in practice for almost 15 years, I have come across many such instances where the cause is not known. We are reacting to this disease. This disease is very big. We are reacting to this disease, and the best way forward is by understanding the genetic makeup and the molecular structure and how cell processes are happening. So I counsel all my patients. This question actually all patients ask me, why me? Why this has happened to me? And virtually I don't have any explanation for that. There are certain cancers which are caused by alcohol, which are caused by cigarette smoking, which are caused by viruses. But majority, more than 50-60% of the cases, you don't have any known cause. It's just a matter of chance. These are the cells which divide, keep on dividing in everyone's body. Sometimes there is some problem in those cell division, and then these mutations are there. The latest concept which is now being developing is the immune theory of cancer. That is that we do have a cancer directed immunity inside our body. Every individual has. When the cancer finds out a way to evade that thing, it becomes autonomous. So mostly mutations are taking place in everyone's body, but not everyone gets cancer. Some instances are there, it's a matter of chance, you might say, that these mutations find out a way to evade the immune surveillance or the body's resistance mechanism, and then that cell, that one single cell, gets an unfair advantage or survival advantage, and that explodes into a tumor.
Okay, that was such an enlightening discussion about the case. So let's move on to the next question, Dr. Vaibhav. So liquid biopsy have really caught the public attention as it is non-invasive, high-tech, and supposedly game-changer technique. So in your practice, how has the technology changed how you monitor treatments, response, and resistance in stage 4 patients?
Yeah, obviously, liquid biopsies have come up a long way from being an experimental tool to something which I consider for a lot of my patients now. It's an unmet need, because ultimately, when we want to practice precision medicine, when we want to treat the patient, we are at the mercy of that tissue, that biopsy. And that biopsy is not always easy, not always possible. It is painful. Sometimes patient might have a tumor in such places where biopsy is not at all possible. So there, this liquid biopsy with the new standard platforms which have come in, they are very, very helpful. You get to study, you get to know what exactly mutations are there. And now with the new standardization, they are as good as the solid most of the times with the standardized test. But this is to be used with a caution that you should actually order such a test where you have a lot of data, and there are few tests which are like approved as well. So you should actually pick and choose those patients. Right now, it has not gone to a stage where it can replace the solid biopsy. Again, that is a very overhyped thing to say there is no need of biopsy, because there are certain informations like the tissue of origin of cancer. For example, if you find something in liver or metastasis and we did a biopsy, and there is no way of doing a liquid biopsy and finding out from which organ this has come to liver. That can be achieved by putting a needle in the liver, taking out the piece and doing immunohistochemistry analysis, IHC analysis. That will give such clues that it has come from breast, or it has come from some hidden primary in the lungs. So, or colorectal, which might be missed sometimes in the scans and all, so that we can actually do the scopy and find out the primary. So for diagnosis, I don't think liquid biopsy is there for prime time. For follow-up, one may take comfort and see that there is some concept of minimal residual disease. You do a liquid biopsy and there are no cancer DNA, ctDNA, everything is negative. You can actually think that yes, the patient is free of tumor. But again, there are certain tumors which don't shed that kind of a DNA in the blood. So that science is not perfect. It is far from it. So I will not recommend liquid biopsy in a routine case for monitoring or surveillance of cancer who are on therapy. We are not there yet. There are many caveats and the process needs to be standardized. Yes, liquid biopsy does have its value because it has a faster turnaround time. For a solid biopsy to give results, for example, if a lung cancer patient comes to me in a very, very bad situation, I want to know the molecular structure, diagnosis and mutations, then a solid biopsy and an NGS will take at least 15 days. Liquid biopsy turnaround time is 7 to 10 days. And with the same efficacy of picking up mutations, where this is a case where I know that it is a primary lung cancer and I am interested in the targeted therapy. So there I utilize it quite often. There are instances where I do both the tests together, that is solid as well as liquid. They are complementary to each other because there is enough data to suggest that when you do a solid and a liquid test together, there are certain portions which will not come up in liquid, and there are certain mutations which will be missed by solid. So there is a concept of complementary testing, and that also is being adapted for certain tumors where you don't want to miss out on anything. But again, it is not a standard of care. Standard of care right now is solid tumor biopsy, and liquid biopsy, maybe with more refinement, will in future days we might see it coming close to replacing solid, but not yet.
Okay, thank you so much, Dr. Vaibhav, for joining in today. And we had a really enriching session regarding precision oncology. Thank you so much for joining us today.
Thank you. Thank you.
And thank you to our viewers for tuning in. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate us to join our MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay tuned, stay healthy, take care.